My name is David Denning and I work at the University of Manchester and have been looking after patients with fungal diseases for nearly 40 years. Today I'm going to tell you a little bit about Histoplasma and the diseases it causes, that is to say histoplasmosis. So our intended learning outcomes today are to understand the epidemiology and pathogenesis of histoplasmosis, to be aware of the really quite diverse clinical manifestations of this disease, and also to appraise you of how the diagnosis is made in the different settings. So there are a number of different endemic fungal pathogens. These include Histoplasma, and there are two species, Histoplasma capsulatum, variety capsulatum, and Histoplasma capsulatum, variety duboisii. Blastomyces dermatitidis, another recently described closely related species, cause endemic mycoses. There are two species of coccidioides, which are indistinguishable in terms of their clinical manifestations. Paracoccidioides, which is restricted to certain parts of South America, is caused by a pair of species, Paracocci brasiliensis and Paracocci lucii. Talaromyces, or what was called Penicillium marneffii, is restricted almost completely to Southeast Asia and is particularly associated with opportunistic infections in AIDS, although it's also a dimorphic pathogen. And in southern Africa, what was thought to be histoplasmosis has now been described as being caused by a new genus called Emergomyces. All of these pathogens have a degree of dimorphism, particularly thermal dimorphism in terms of their temperature, and they can certainly cause invasive disease in immunocompromised patients, but they also cause disease in people who are apparently immunocompetent. Almost all of them have restricted geographical ranges, although as you'll see, histoplasma is quite widespread. So dimorphism describes two different morphologies of a fungus, varying between a yeast form and a mold form. In fact, there are other forms of molds in terms of their morphology, such as arthroconidia, but I won't go into that today because with histoplasma, it is fairly straightforward. On the left-hand side, you have yeast cells, which are what is found at 37 degrees at the body temperature, and on the right-hand side, you have a mycelial phase, which is a more fluffy mold, which is found at lower temperatures and in the environment. So in nature, the histoplasma exists as a mold, but in human tissue, it is a yeast, as I've indicated, and the size of those yeasts are very different, so that Histoplasma capsulatum is 2 to 5 microns in diameter, and it's really quite a small yeast and can be confused with leishmaniasis, whereas Histoplasma duboisii is really quite a large yeast, larger than most other yeasts that you might see under the microscope, and also has thicker cell walls. So Histoplasma capsulatum is found in soil enriched with bird or bat droppings. The natural environment of Histoplasma duboisii is not well understood, and this organism hasn't been found in the environment in any quantity, and therefore it's difficult to know where it exists. So Histoplasma capsulatum is particularly found in the Americas, and the area around the Mississippi and Ohio rivers in the Midwest are particularly prevalent areas, but it also extends, as you can see, to Texas and other areas up in the Great Lakes area, for example, and there are a few cases found in Canada. It's got some overlap with the areas endemic for blastomycosis as well, which is usually further north. And then there are many endemic areas in Central and South America. Guatemala is a particularly intense hotspot, and the Guiana Shield, including Suriname and French Guiana, are also areas with very high prevalence, along with Venezuela. In Southeast Asia, Histoplasma is found in India, Myanmar, in certain areas quite intensively, in Thailand, Malaysia, Philippines, Indonesia. It's also found in southern China, and it appears to have a patchy distribution, just as in the Americas you get these sort of microfoci where there's intense transmission in certain areas and then not very far away there is less transmission. In all of these situations you can get sporadic cases in non-endemic areas because people have travelled to endemic areas, but it's harder to define the limits of those endemic areas for histoplasma. A few cases have also been described, for example, in Australia. Histoplasma capsulatum is also found in Africa, but the areas where duboisii is found is almost exclusively Africa. There have been a couple of cases described from India, but it's almost exclusively Africa. And you can see on this map the areas with the highest incidence, which is based on reported cases, which may or may not be an accurate reflection of where the disease occurs most frequently. So the infection occurs following inhalation of microconidia. So as with most other endemic pathogens, it's an inhalation disease. The immunocompetent individuals are usually asymptomatic, although you can, as I'll show, develop acute pulmonary histoplasmosis when you inhale a large inoculum. Acute infection clears in a typical person who's immunocompetent, and you get cell-mediated immunity, and that person is then probably immune for life. Although if they subsequently become immunocompromised, you may get emergence of disease, indicating that long-term latency is quite likely. T lymphocytes are critical for protection against histoplasma, particularly gamma interferon and alpha TNF. When the microconidia are engulfed, this happens through various phagocytes, particularly macrophages and monocytes, and you get granuloma formation. And this latent infection can occur, or can reoccur, if you like, many, many years after exposure to an endemic area. So a long travel history may be helpful in terms of making a diagnosis, or at least suspecting this infection. And progressive disseminated histoplasmosis occurs in previously infected people who become immunocompromised because their immune system is impaired. So on the left-hand side of this slide are the summary of the different forms of histoplasmosis caused by capsulatum. So you get this acute or subacute pulmonary histoplasmosis, and that can become chronic, and you can also have nodules as one of the manifestations of disease. You can have disseminated disease, which is often called progressive disseminated histoplasmosis. This organism also goes to the mediastinum, and you can get granuloma formation there, fibrosis, and also quite marked lymphadenopathy in occasional cases. And there are rarer forms of histoplasmosis, for example, ocular or bronchiolithiasis or meningitis, and occasionally this presents also as an acute adrenal mass, which is one of the less common forms of disease. In contrast, Histoplasma duboisii infection, which is otherwise known as African histoplasmosis, has a much more indolent clinical course, and pulmonary disease is quite rare. Common manifestations include various papules or nodules on the skin and cutaneous abscesses. Bone involvement is relatively common, around 30%, and you can also have arthritis. And this infection can also complicate HIV in Africa, and it presents then with fever, weight loss, and disseminated disease, and unfortunately responds poorly to therapy, although that may be a reflection of the therapy that's given. So the initial manifestation with a high inoculum is called acute pulmonary histoplasmosis, and 90% of patients who inhale this organism develop a subclinical self-limiting infection and really don't know that they've had it at all. But if you have a higher inoculum exposure or virulent strains, you can get a more marked illness. But even normal people can develop acute pulmonary histoplasmosis. The onset is over 1 to 2 weeks with fever, chills, dyspnea and cough. And some patients get arthralgia, arthritis and erythema nodosum, which are immunological manifestations of the disease. On the chest imaging, you get enlarged hilar or mediastinal nodes typically. And you also, in the more severe cases, get bilateral patchy opacities. Occasional patients can go into acute respiratory distress syndrome, and it can also lead to disseminated disease, particularly in those who are immunocompromised, but not exclusively in those patients. So this is another example of acute pulmonary histoplasmosis on the left, with a patient who's previously had it with mediastinal calcification. But the acute presentation is typically with fever and headache, and then chills, cough and chest pain. So these are non-specific features and not very helpful, with perhaps the one exception of chest pain, which is uncommon in many upper respiratory tract infections. If you have erythema nodosum or erythema multiforme, that's helpful, and some patients have hepatosplenomegaly. And if you have mild disease and a low inoculum, then you have a fever for a short period of time and it's not a particularly high fever. And in contrast, if you inhale a lot of histoplasma, you can have a really very high fever and be ill for between 9 and 18 days. And some patients die of this infection if it's not diagnosed and treated in the severe category. Notably, a chest X-ray is normal in 75% of patients, but you do get calcification subsequently in some patients. So disseminated histoplasmosis is divided into acute progressive, which is typically in immunocompromised patients, particularly HIV patients, or a subacute or chronic disseminated situation. And acute progressive disseminated histoplasmosis is an AIDS-defining illness. 41% of patients in French Guiana, 70% of patients in Colombia. And it's more common than TB as an initial presentation of HIV in Guatemala, for example. Hematogenous dissemination occurs only in about 1 in 2,000 following acute pulmonary histoplasmosis, and it may be that these patients have some defect in cellular immunity. So the risk factors that are known for this disease include HIV, particularly very low CD4 cell counts, less than 50 is common, although some patients can present at less than 100 or less than 200. It also occurs in very young children and older adults. There are cases reported with idiopathic CD4 lymphopenia. It is a complication of common variable immunodeficiency and Job's syndrome or IgE syndrome. And in patients who have a defect in IL-12 or gamma interferon or the adult immunodeficiency syndrome, this is one of the presentations. And again, it's not a very specific clinical presentation. There usually are respiratory symptoms, fever, fatigue, malaise, and weight loss. But as you know, these are not very distinctive. But these features, together with lymphadenopathy and hepatosplenomegaly, which are quite common, should alert you to the diagnosis. Skin and oral lesions are also found, although they're a little bit less common in some locations and some cases with Histoplasma capsulatum infection as opposed to duboisii infection. Gastrointestinal symptoms are also found in some patients, and that's a differentiating feature from tuberculosis. In the labs, the pancytopenia is particularly common, and elevated liver enzymes and bilirubin is also found fairly commonly. So other manifestations of disseminated histoplasmosis include shock, renal failure, ARDS, and a DIC consumptive coagulopathy. The organism can be found essentially anywhere, including the liver and the spleen and the gut, but the bone marrow can be sampled, and this is one of the ways that the diagnosis can be made with the bone marrow exam and staining for fungi, and also culture, although the culture takes a long time. You may find skin lesions. They may be found in the adrenal glands, on the CNS or the endocardium. On chest imaging, miliary infiltrates are seen occasionally in patients, but you also can get diffuse reticular nodule or interstitial infiltrates in some patients. Some patients suffer adrenal insufficiency along with this shock syndrome, and so corticosteroid replacement may be life-saving. And some get reactive hemophagocytic syndrome, and you can also get various CNS features which are challenging in terms of management. So another way of thinking about this is the frequency of these different features. So fever and malaise are common, cough is found in 30%, a skin rash which may be found around the umbilicus in 10% of patients, 30 to 50% of patients have pancytopenia, and a similar number liver dysfunction and hepatomegaly, and about 25% have splenomegaly. And you often have a marked elevation of AST compared with ALT in disseminated histoplasmosis. So the typical CD4 count, as I mentioned, for presentation is less than 50, and this chart from French Guinea shows that very clearly. But you can get cases presenting with CD4 counts higher than this, 50 to 100 or 100 to 200, although it's slightly more likely to be tuberculosis in those situations if the two diseases present together. And some patients have both tuberculosis and histoplasmosis. Here's an example of a molluscum contagiosum type of skin rash which is found, and these lesions can be biopsied and the diagnosis made very rapidly, which is helpful, but most patients don't have a visible skin rash. So another manifestation is chronic pulmonary histoplasmosis. This is probably most common in smokers and men over the age of 50, and the presentation time is usually over months or years. Productive cough, dyspnea, chest pain, night sweats and weight loss are very typical, and radiologically it's similar to tuberculosis, although it doesn't look quite the same, and so it may be mistaken for TB, and certainly these symptoms are very characteristic of TB. The infiltrates are usually in the upper lobes, but you can also get consolidation and cavitation, and it is difficult to distinguish the features definitively from tuberculosis in areas where there's a lot of tuberculosis. And chronic pulmonary histoplasmosis has also been reported in patients who've no underlying diseases and in patients who are non-smokers. These days, nodules are a more common feature radiologically, and these can be mistaken for lung cancer in some patients. As I mentioned earlier, mediastinal disease is a particular feature of histoplasmosis, and you can get lymphadenopathy in the mediastinum, you can also get granulomas, but you get also a late complication of fibrosis, mediastinal fibrosis, which is really a very difficult management problem, quite rare, and fortunately, because it's quite a difficult thing to treat. And so with these you can get compressive symptoms, for example, which are very common with mediastinal fibrosis, but not so common with adenitis. Granulomatous found, but in the fibrotic mediastinal fibrosis, calcification is particularly common, and that's not found in the mediastinal adenitis. Various forms of chronic disseminated histoplasmosis, including GI symptoms, and here's an example of an ulcer next to the anus, and you can get similar lesions in the nose or the mouth or the lips, which can be found, or in the GI tract, which can be seen on endoscopy. In the middle, you can see very enlarged adrenal glands, which have been removed because of a concern of malignancy. And on the right lower CT, you can see these very large adrenal glands, which are present which are non-homogeneous, which is a clue to the diagnosis. And a biopsy of these will usually yield histoplasma under the microscope. And this interesting graphic from about 40 years ago from one of the major textbooks of medicine, which includes a chapter on histoplasmosis, shows the pathology from severe, moderate to mild, the amount of organism present, and on the left-hand side, whereas with mild disease you get more of a granulomatous disease and more chronic disease, a much more acute presentation on the left and a much more chronic presentation on the right, and this was written and described pre-AIDS. And also, again, you get more fever, hepatosplenomegaly, pancytopenia, and interstitial pneumonia in severe progressive disseminated histoplasmosis, whereas the mild chronic forms of disseminated histoplasmosis give you much more oropharyngeal ulcers, maybe features of Addison's disease as a typical feature. So how do you make the diagnosis of histoplasmosis? There are various approaches. There's microscopy, there's culture, but culture is slow. There's the PCR tests. There are skin tests, which are helpful for diagnosing previous exposure and latency, but not active disease, and both antibody and antigen tests. Direct microscopy is particularly helpful for this organism in patients with disseminated histoplasmosis. In the blood smear, you can occasionally see yeasts in using a Grocott or usually a right stain on blood or on bone marrow. And that is a helpful feature because if you see that, then it's pretty definitive. Sometimes it's not entirely clear whether you're dealing with histoplasma or leishmaniasis, and that is the only key differentiation. On tissue sections, if you have tissue, then you can see these organisms as well. And in addition to leishmaniasis, you've also got Candida glabrata, which is one of the other important differentiations. Talaromyces malnefiae tends to be a fission yeast and a bit longer and isn't a budding yeast, so that differentiation should be possible, although sometimes it can be difficult. Culture is required for definitive identification of the organism, obviously, but it takes 4 to 6 weeks to grow this organism. So in patients with disseminated disease, this is too slow, and many patients in the early phases of the AIDS epidemic who were diagnosed by culture had died by the time the culture became positive. It's also necessary to confirm the nature of the organism, and conversion from mold to yeast, which is usually because these are cultured at 25 to 30 degrees, so it comes up as a mold to begin with, is important to confirm that it's a dimorphic fungus and it's consistent with Histoplasma. The sensitivity of culture is reasonable, 60 to 85% on sputum and BAL fluids, but multiple samples are often required. It sometimes comes up in TB cultures as well. Bone marrow gives you a higher yield and CSF gives you a lower yield. As I'm sure you know, this is a class 3 pathogen, so these organisms should be handled in a class 3 environment, so typically in the TB facility, but without contaminating the TB cultures. There are antibody tests for Histoplasma, although some of these are not particularly sensitive, but a seroconversion after acute pulmonary histoplasmosis is the way the diagnosis is usually made, sometimes combined with development of calcification on a chest X-ray. Clearly, in immunocompromised patients, the antibodies may be negative. There are different antigens that come up on a precipitins assay, and these tests probably need a little improvement and shouldn't be done unless you think it's quite likely as an infection. It's also probably the only way to make a diagnosis of chronic pulmonary histoplasmosis, with the one exception of culture, which occasionally comes up positive but not very often. There is cross-reactivity with blastomycosis and coccidioidomycosis. Antigen testing is the optimal way of making a diagnosis of acute disseminated histoplasmosis. It's actually a galactomannan antigen, so quite similar to Aspergillus, although there are some differences. And there's cross-reactivity for that reason with blastomyces, coccidioides and paracocci, and possibly with Talaromyces as well. On urine in patients with HIV infection, or serum actually, the sensitivity of antigen is between 50 and 80%. In some series, particularly patients with late-stage HIV and very low CD4 counts, the sensitivity gets up to 90%. But with a broader range of patients, it's not quite as good as that. But you also have the possibility of a positive antigen test in chronic pulmonary histoplasmosis, as well as the pulmonary features of acute disseminated disease. And the data on that is not very good, but it suggests that actually the antigen is helpful in that disease. So you can see that these different clinical manifestations give you different sensitivity of the assay. And if you're considering a diagnosis of Histoplasma meningitis, then the antigen test on the CSF is probably the best means of making that diagnosis. So you can do these skin tests, which are based on latency and prior infection. And this is an example of a study that we conducted in Nigeria of a positive test. And you measure the diameter of the wheal, which comes up after 48 to 72 hours. And that tells you if the patients have been exposed to infection. Histoplasma probably cross-reacts with Histoplasma duboisii, but based on a limited data set, and therefore it might not distinguish those two infections in Africa, but outside Africa, probably pretty specific for Histoplasma. And a negative test does not rule out current infection or recent infection because it's got a low sensitivity. So in summary, histoplasmosis is caused by two quite different species in epidemiological terms, capsulatum and duboisii. Formally, they haven't been separated as species and are regarded as varieties, but from a clinical perspective, they're very different indeed. Duboisii infection is mainly extrapulmonary with a very slow subacute or chronic course. Acute disseminated histoplasmosis is a really important AIDS-defining illness in areas with high prevalence, particularly in the Americas. After acute infection, antibody develops in patients, but may be negative in immunocompromised patients, and is not also very good for diagnosing chronic adrenal infection in patients with adrenal enlargement. Bronchoalveolar lavage samples provide the highest yield in patients with chronic pulmonary histoplasmosis, but again, antibody may be positive in these patients. And the Histoplasma skin test should only be used for epidemiological studies. Many thanks for listening, and I hope that's helpful to you.